Welcome to this series where I'll be reviewing the 2025 AACE Consensus Statement on the algorithm for the management of adults with dyslipidemia. This is Endo in a Bite, where I break down complex concepts into bite-sized pieces you can actually remember. Let's begin. Today we will discuss extremes in HDL concentration. Extremes in HDL concentration, either markedly reduced or markedly elevated, are not benign findings. They frequently signify underlying metabolic, genetic, or secondary pathophysiologic mechanisms rather than simple physiologic variation. Let's begin with the low HDL phenotype. Genetic syndromes resulting in profoundly reduced HDL are rare. They're often identified incidentally, usually in the workup of other manifestations such as corneal opacities, xanthomas, peripheral neuropathy, renal dysfunction, or enlarged orange tonsils. Secondary causes are more common. These include renal disease, low estrogen states, hyperandrogenism, and paradoxical reductions in HDL seen with fibrates, TZDs, or combined therapy. Among heritable causes, pathogenic variants in the ABCA1 gene represent the most frequent monogenic etiology. Heterozygous carriers generally have HDL levels below the 50th percentile for age and sex. In contrast, Tangier disease, resulting from biallelic ABCA1 variants in an autosomal recessive pattern, is characterized by near-absent HDL, typically below the 5th percentile. Two other rare causes, LCAT deficiency and fisheye disease, arise from biallelic LCAT variants. These syndromes produce low HDL, accompanied by proteinuria and corneal clouding. Such ocular findings should immediately raise suspicion for an underlying enzymatic defect in HDL metabolism. I once heard a mnemonic in a lecture that stuck with me. Fish have cloudy eyes and cats love fish. It's a simple way to remember corneal clouding seen in fisheye disease and LCAT deficiency. While these genetic syndromes were historically diagnosed only in research contexts, clinical accessibility of next-generation sequencing panels targeting lipid genes has expanded, enabling more widespread identification of monogenic HDL disorders. Now, on the opposite end of the spectrum, HDL concentrations above the 90th percentile are most often secondary rather than genetic. Common secondary causes include chronic excessive alcohol consumption, anti-epileptic drug use, pharmacologic niacin, estrogen therapy, and pesticide exposure. Genetic causes of extreme HDL elevation are rare and are typically due to CETP deficiency or loss of function variants in lipolytic enzymes responsible for HDL remodeling, specifically hepatic lipase and endothelial lipase. Although these variants elevate HDL substantially, they do not necessarily confer cardiovascular protection, as HDL particles may be functionally impaired in reverse cholesterol transport. When confronted with extreme HDL values, either low or high, the diagnostic evaluation should follow a systematic evidence-based approach, confirm the abnormality, repeat a fasting lipid profile to exclude spurious results due to analytic variability, acute illness, or transient physiologic fluctuations. Review historical data to assess chronicity, evaluate for secondary causes. Conduct a comprehensive medication and exposure review. For low HDL, consider renal impairment, endocrine disorders, and drug-induced dyslipidemia. For high HDL, assess for alcohol excess, anti-epileptics, niacin, estrogens, or pesticide exposure. Assess for syndromic features suggestive of genetic etiology. Findings such as corneal opacities, orange tonsils, neuropathy, xanthomas, or renal dysfunction should prompt suspicion for monogenic defects, most notably Tangier disease or LCAT deficiency. A note about Tangier's disease, I heard a mnemonic that stuck with me: orange tonsils, tonsils like a tangerine, are seen in Tangier's disease. Order genetic testing when indicated. Utilize targeted sequencing panels covering ABCA1, LCAT, APOA1, CETP, LIPC, and LIPG, depending on the clinical phenotype. We can also test for SCARB1 or APOC3, again, depending on the phenotype. Referral to a lipid specialist or medical geneticist is appropriate for interpretation and counseling. Integrate findings into cardiovascular risk assessment. It is critical to remember that HDL quantity does not equate to HDL functionality. Extremely high HDL may paradoxically reflect dysfunctional particles with impaired cholesterol efflux capacity. Similarly, very low HDL often coexists with other metabolic derangements, amplifying cardiovascular risk. In secondary forms, treatment focuses on the underlying cause, adjusting or discontinuing offending agents, optimizing renal and endocrine function, and addressing lifestyle contributors. For genetic disorders, management is largely supportive, emphasizing cardiovascular risk mitigation through aggressive control of LDL cholesterol, blood pressure, and other modifiable factors. To summarize, extreme HDL values on either end of the spectrum are never trivial. They should trigger a deliberate diagnostic evaluation incorporating biochemical confirmation, secondary cause exclusion, phenotypic assessment, and, when appropriate, genetic testing. Low HDL often reflects ABCA1 or LCAT-related pathology or secondary metabolic disease. High HDL may indicate CETP, hepatic lipase, or endothelial lipase deficiency, but far more commonly stems from pharmacologic or environmental exposures. Ultimately, HDL extremes are biochemical signposts pointing toward underlying metabolic and genetic derangements. Interpreting them accurately requires integrating lipid data with clinical context, systemic findings, and exposure history. Let me say this in one more way. AACE has specifically mentioned 8 conditions, and let me go through them one by one. For the low HDL, the hypoalpha-lipoproteinemia, they mention ABCA1, LCAT, and ApoA1. ABCA1 is Tangier's disease, the one with the orange tonsils. Extremely low HDL, orange tonsils, hepatosplenomegaly, neuropathy. Here there is impaired cholesterol efflux from macrophages to ApoA1. LCAT deficiency is the one with the corneal opacity, eye like a fish. Familial LCAT deficiency or fish eye disease has low HDL, corneal opacities, anemia, and renal disease. And the third hypoalpha-lipoproteinemia they mention is ApoA1. ApoA1 deficiency due to a reduced or defective ApoA1 synthesis or structure. There is low HDL, xanthomas, premature coronary artery disease. Now, in the 5 conditions that they mention for high HDL, CETP deficiency. In the board, they always mention Japanese heritage, but basically CETP deficiency has markedly elevated HDL, large HDL particles, paradoxically not always cardioprotective. And then there is SRB1 deficiency, the gene being SCARB1. Here, there's an elevated HDL and a paradoxical increased cardiovascular risk. And then they mention hepatic lipase deficiency and endothelial lipase deficiency. Hepatic lipase deficiency gene is LIPC. Endothelial lipase deficiency, the gene is LIPG. In hepatic lipase deficiency, there's elevated HDL, elevated triglycerides, and enlarged HDL particles. In endothelial lipase deficiency, there's elevated HDL, normal LDL, uncertain CV impact. And then the last one is ApoC3 loss of function. In the ApoC3 loss of function, the gene is ApoC3. Here there's a high HDL. It's actually cardioprotective. And here there's inhibition of lipoprotein lipase. Variant forms reduce triglycerides and modestly raise HDL. This was another bite-sized episode of Endo in a Bite. If a detail went by too quickly, do not worry. I've prepared notes for you. Visit www.easyendoprep.com to sign up for the newsletter and have all the key pearls delivered straight to your inbox. You can also explore the full board review course there for deeper learning and ABIM exam preparation. Remember, stay consistent, and together we'll work through the AACE consensus statement on the algorithm for management of dyslipidemia, one bite at a time.